Good morning, everyone. My name is Dr. Piyush Ojha. He's Dr. Mitlesh. On the behalf of Department of Neurosciences at Medanta, we welcome you all to the exciting morning session, which will be discussing about various aspects of stroke. So without wasting much of your time, I would like to welcome Dr. P N Renjen. He needs no introduction. He's currently working as a senior consultant neurologist, stroke and academic advisor at the Institute of Neurosciences at Indraprasth Apollo Hospital, New Delhi. He has been the past president of Delhi Neurological Association. He has been an EC member of European Stroke Organization from 2015 to 18. He's also been on the editorial board of the Cerebrovascular Diseases. He has more than 100 publications and more than 10 chapters in his book. Without wasting much of your time, I would welcome Dr. P N Renjen sir on the dais to briefly introduce about the course and discuss the brief aspects about stroke. Thank you.
Thank you. Good morning, everybody. It's a pleasure to be here at 8 o'clock in the morning. And I thank Arun for giving me this opportunity to conduct this workshop on stroke. You know, you would have seen that there are excellent speakers and excellent topics to make you aware what acute ischemic stroke is, when do you thrombolize, and when do you go for thrombectomy. My introduction already has been said, except I can only say one thing, that the Apollo Hospital runs a very good stroke program, which I take care of. Now, I would like to now shortly introduce the other speakers before I go forward. We have with us a very, very good collection of speakers. Dr. Neeraj Bhutani is here from Jaipur, who is going to speak about the pre-thrombolysis workup. Then reading CT and MRIs, which is very, very important in acute stroke, will be done by Dr. Anshu Mahajan from Medanta. Puneet Agarwal, our very good friend from Max, he's the director of neurology in Max, will talk about the IVT bridging therapy. As you all know, still there is a controversy whether you should give IVTPA or you should stay do thrombectomy or you should do thrombectomy only, which Puneet will cover. Again, I'll come back again to tell you how do you identify patients for mechanical thrombectomy. It's very important that whatever you do in stroke, because stroke is a very, very complicated disease, whatever you do should be in the best interest of the patient. Gaurav Goel from Medanta will speak on mechanical thrombectomy, and Dr. Puneet Agarwal will come again to talk about the post-IVT monitoring, and the discharge advice will be given by Neeraj Bhutani. Now, why did Arun Garg think of putting a topic like recognizing stroke? Obviously, all of you would think, what's so difficult in recognizing a stroke? But please be rest assured, it's not that easy. You've got stroke mimics, you've got stroke chameleons, and especially so in the posterior circulation strokes, very, very often errors are made. Now, all of you sitting here who are interested in stroke, without wasting much time, to tell you that we classify ischemic stroke. When you start treating a stroke, please classify a stroke. This is the TOAS classification, which I'm sure everybody in this hall is quite aware of. Is it a secular stroke? Is it cardioembolic? Is it cryptogenic? And you know, now we talk about ESAS, we talk about cryptogenic stroke, we talk about ESAS, and so many other things. So you should know really what you are treating. You show this over time slide of an ischemic penumbra, which I think is really a wonderful slide. You have an infarcted area where the cerebral blood flow falls very fast. And this is surrounded by a marginally perfused brain. So what you and I are interested in is to look after this marginally perfused brain by thrombolytic therapy. So that is why I say time is brain, 3 hours, 4.5 hours. All this is said because really time is brain. I like this slide very much. This is from Jones. If you see the paralysis on one side and you see the infarction, if you wait, this is what you do to the patient. There is no doubt about the fact that early treatment remains essential. I always stress in my unit at least that even if a patient comes in 1 hour, don't wait for the second hour to come. Thrombolize as early as possible, because you're going to get better result if you thrombolize early. Now this slide I'm just showing, because as a neurologist, as a stroke neurologist, when I start treating a stroke, when I start thrombolizing thrombectomy, I always like to know which is the artery affected and which is this. Is it an ACA? Is it an MCA? Is it a PCA stroke? So, what is the evaluation of a stroke? Determine first and the foremost if symptoms are because of a stroke. 2, importantly, localize the brain lesion. Establish the type of stroke. Is it cardioembolic? Is it lacunar? And ascertain the likely cause. The clinical assessment will be general physical, which remains the cornerstone of the evaluation. The use of stroke rating scale, NIHS, is recommended. It has been recommended that patients with acute stroke of less than 7 days of progression should be admitted. This is the usual question we are asked, we answer. Now, these are the symptoms which I won't go into, the right brain and the left brain, depending on the injury. Now, this slide is a very interesting slide that in the emergency or in the triage, you just want to be sure before even you do a CT that is it an ischemic stroke or is it a hemorrhagic stroke? Loss of consciousness, headaches are very uncommon in ischemic strokes. Vomitings are very common and again in ischemic strokes. TIA are usually positive. Gradual onset is a TIA, a crescendo TIA, and activity is positive in a hemorrhagic stroke. This will to some extent right in the triage assess to you to say whether you're dealing with a hemorrhagic stroke or an ischemic stroke. Now, I'm not going to go into this because most of you should know the NIHS score. Person who doesn't know the NIHS score, I'm sorry to say, should not do stroke. The NIHS score is, 0 to 42, mild, moderate, severe. So it's your duty, before you thrombolize, before you think further, which artery is affected, which area is affected, and what is the NIHS score. Again, the MCA infarction, you all know, produces gaze paralysis, homonymous hemianopia, and dominant hemisphere, they produce aphasia, and non-dominant hemisphere is a neglect. The ACA infarctions, again, you would ask me, what's the point wasting your time with the ACA or MCA? ACA, ACA will involve more of the lower limb, there'll be great apraxia, and there'll be ebulia. And this is what you will get in a PCA infarction, and this is what you'll get in a vertebral basilar. This is a very busy slide. For those of you who are interested, I'm not going to talk over this slide, but please go And look at this slide, which very beautifully talks about large vessel stroke syndrome, assuming left hemisphere is dominant. Now, I, as a stroke physician, must balance the clinical principles of stroke and prima nocere need for accuracy, primum non tardi need for speed. So you require accuracy in stroke, you require speed in stroke, but please make sure that as far as possible, you don't do harm to the patient. That's the bottom line. Every other day in my triage, my resident will come running to me, sir, there's a stroke, should I thrombolize? I say, hang on, let me come. On 2 or 3 occasions, these were straightforward focal seizures. So please, be very careful. Now, what is a stroke mimic and what is a stroke chameleon? What looks like a stroke is a stroke. Looks like a stroke but is not a stroke, is a mimic. 2, does not look like a stroke is chameleon. Does not look like a stroke is not a stroke. So please remember, this was our own publication, a lesson to learn, which we learned the lesson on stroke mimics, and that's why I wrote this review article on stroke mimics. Stroke mimics, please remember, account for about 20 to 25% of acute presentation, many of which can be suspected from the history. The 5 most stroke mimics are seizures, syncope, sepsis, migraine, and brain tumor. Posterior circulation strokes are misdiagnosed 3 times more often than anterior circulation stroke, as they frequently present with non-specific symptoms like dizziness, vertigo, dysentery, or headache. So this is just to show you the same thing, the neurological condition, the infection, the cardiovascular, psychiatric, inner ear condition. Now this is a very nice slide. The 20 most common causes of stroke mimics identified in a systemic review and meta-analysis, and the commonest was seizure, then syncope, and then sepsis. So if you're going to have 20 to 25 of patients who are going to have, please be very, very careful before you do anything. Now this is a very good paper, Safety of TPA in Mimics. I just picked up this paper because I was quite interested to see that if in my unit a stroke is not a stroke and is thrombolized by my team, am I going to do how much of harm to my patient? But this study showed that their data showed that the safety of administrating IV TPA to patients with suspected stroke, acute cerebral ischemia within 3 hours of symptom onset, even when the diagnosis ultimately is not to be a stroke, imaging does not show infarct, you may not do much harm, but that does not mean you should still thrombolize these patients. Now these are the, which you're all aware of, chameleons, which is very difficult to pick up in a triage. You're all in very, very, what should I say, in a hurry. Thalamic strokes, limb shaking TIs, cortical, critical carotid stenosis, cortical stroke, bilateral occipital stroke, TIs in transient ischemic attacks are the chameleons which you should be very, very aware of. The stroke chameleon is an initial diagnosis in about 30.9% of patients who present with mental status, syncope, hypertensive emergency, and suspected acute stroke similar. I will not talk about the neuroimaging because we have Anshu who's going to talk about it. So I'm going to skip these slides and leave it to the clinical part only. And I just, in the end, before I wind up, we've got at least in our hospital, we have started the rapid AI system, fantastic. I think all those who stroke should have this rapid AI system, a fantastic system, which is a CT-based system. Thank you very much for a patient hearing. We are not going to have any questions, answers now because I've been told by the organizer that is the end of the thing. So we go on to the next stop. That's pre-thrombolysis workup. What you need to do, what you need to not to do, where do you start, where do you end. Could I call upon Dr. Neeraj Bhutani to please take over?
चेंज करो. मेरा पीपीटी कहाँ है? ना ये नहीं, प्री थ्रोम्बोलिटिक ये चौथा वाला. हाँ. Good morning, everyone, and thank you, Dr. Renjen. I would be talking about pre-thrombolysis workup, and as we all understand that the aim of pre-thrombolysis workup is to select the patients who are likely to benefit from IV thrombolysis, and then to assess their safety issues that whether it is safe to administer IV thrombolysis or other revascularization through MT in them or not, and then to take cognizance of some special clinical situation because every patient is different, so you may be having some special clinical situations. Then to take consent also, so we have to initiate consent process immediately because patients take a lot of time in giving consent, and to do this in a minimum possible time because we don't want a very long door to needle time. So this is our aims, and to fulfill these aims, these are the tools available to us. So first is clinical history and examination, the age-old tool. Then in our emergency, we have a lot of checklist protocols, and then we have to get certain lab values. So checklist mainly contains the patients where you should rule out absolute contraindications or look for relative contraindication. Protocols are there to check eligibility, and we need certain basic lab values before going for thrombolysis. And then, of course, we have imaging, and we can divide it into three parts. That is our base image or image of brain parenchyma, then image of brain vasculature, that is angio, and then we have certain special imaging tools like rapid software, which are not available everywhere. So coming to the first tool, that is clinical history and examination. So first you have to establish the diagnosis of stroke as stressed upon by Dr. Renjen. And once you establish the diagnosis of stroke by clinical history and examination, you have to classify the stroke into a known onset stroke and an unknown onset stroke. So most of the strokes are known onset, and you note down the exact duration, but at least 20% of the strokes may be of unknown onset. So you should note down that this stroke is of unknown onset. And then you have to assess the severity through NIHSS, that is a 42-point scale Dr. Renjen has already shown. And then you take note of any special clinical situations if present, like a recent MI, recent stroke, or a terminal illness, or a recent surgery. So these you have to take note of. Simultaneously with clinical history, you should initiate the checklist. So I am taking these tools one by one, but these tools have to be initiated simultaneously to save time. So while you are taking clinical history, doing examination, your technician can draw blood or someone can run through the checklist. So these things can be done parallelly and you save time. So the basic labs which are required are ABG, electrolytes, sugar, platelet, and INR. These are the basic labs parameter which you need. And then you have to run through the checklist to rule out absolute contraindication. So you do remember that there is a change in status of many of these contraindications. Many absolute contraindications have become relative or now no more contraindications because we want to give benefit of revascularization to maximum patients. So I'm just giving you some examples of what changes in the checklist has happened over last decade or so. So earlier, if you have a MI within 3 months of the stroke, it was an absolute contraindication because there was a risk of ventricular rupture if you administer IV thrombolysis. Now, absolute contraindication has been reduced to 2 weeks. And from 2 weeks to 3 months, there is a relative contraindication if there is an STEMI MI, and non-STEMI MI, there is no contraindication. Similarly, hyperglycemia more than 400 used to be an absolute contraindication. Now it is a relative contraindication. We know that the outcomes are not as good in patients with hyperglycemia, and bleeding tendency is slightly more, but still it is not an absolute now. Dual antiplatelet, you can do IV thrombolysis. See, minor strokes, usually it was recommended that you should not do IV thrombolysis, but now in certain situations you can do. Seizure at the onset of a stroke was an absolute contraindication. Now it is not. Stroke within 3 months was an absolute contraindication. Now it is not. And old ICH was an absolute contraindication. But now if the ICH is very old, like more than 2-3 years, and small ICH, you can still do. So these are the changes we should take notice of. And then the next step is imaging of brain parenchyma, which also you have to do simultaneously. And we have two imaging tools available commonly. One is CT scan and another one is MRI. So thrombolysis is essentially CT based, and it is the investigation of choice because the ease of doing it, it is less time consuming, it is so widely available, and can be performed in irritable patients also, and patients who are non-cooperative. And our main aim is to rule out ICH, which CT can do easily. Now, MRI is preferred in certain situations. Firstly, when diagnosis of stroke is uncertain and you are not sure whether it is a stroke or a stroke mimic, you may prefer MRI because it gives a better idea. Secondly, when the duration of stroke is uncertain, like a wake-up stroke, then MRI is the investigation of choice because as per wake-up trial, you have to look for a diffusion and flare mismatch that in fact has appeared in diffusion but not in flare. And sometimes some neurologists do prefer MRI at the brink of window period in severe strokes because they want to see whether already flare and diffusion changes have appeared and should they thrombolize or rule out these patients. And with the brain parenchymal imaging, immediately you have to do angio. Angio is must for all, and CT angio is preferred over MR angio by most. And the only issue is that when you are choosing MRI as your base imaging, then probably you have to go for MR angio only because shifting the patient to another machine is not possible. But in many centers, if both the machines are in adjacent room, people are doing MRI and then shift the patient to CT angio. So the aim of doing the imaging is to identify the vessel involved. So if there is a large vessel occlusion, you know that the recanalization with IV thrombolysis is only 14-15%. So you have to alert your mechanical thrombectomy team that this patient may need MT. And then you have to assess the collaterals also, which are assessed in late arterial phase. So patients who are having good collaterals, even at the end of the window, they will be having a good viable tissue. So outcome is better. And you can study the clot characteristics also, but clot characteristic doesn't change your decision much. This is a retrospectively, you can study that what kind of clot it was, hard or soft or something. So this is showing the collaterals. So from no collaterals to good collaterals, as you can see. So better the collaterals, better is likely to be the outcome because more chances of viable tissue. And these special imagings are not widespread available, but if it is available, you can use it to study mismatch. The main aim of this special study imaging is to study mismatch beyond 4.5 hours, so you can extend your window. My rapid software is there, which was used in extend trial and diffuse trial for IVT and MT, and then you have CT perfusion and MR imaging. So these are the tools which are available to you for pre-thrombolysis workup. Now, I will take some case scenarios just to exemplify that how various tools can be or various routes can be administered in the given clinical situations. So suppose a 62-year-old man presented with right side weakness and global aphasia of 4-hour duration, and CT scan is done outside, which is normal. So clinically, you may think that probably because of global aphasia, there is a large vessel occlusion in this patient. So one option you have that quickly run through the patients through your checklist, find out the eligibility, do the labs and do IV thrombolysis. Second option you have that you do CT angio because CT is already done and you offer him direct MT if there is a large vessel occlusion, or you can go for MRI brain with angio and see that how much diffusion and flare restriction is there. So in this case, probably as of now, I think you can do the IVT directly because patient is well within the window if is found eligible. And after that, you do CT angio, patient doesn't improve, alert your MT team simultaneously that this patient may need mechanical thrombolysis. Secondly, if a 62-year-old lady with left hemiparesis, gate 2/5 and intact sensorium, 1.5 hours duration. So historically, it doesn't look like a large vessel occlusion, maybe a subcortical stroke. So you have option of CT with angio, then offer IVT, MRI with angio. Obviously, you will run through the labs and checklist to find out the eligibility, then option of special imaging and consider direct MT after imaging. So this is a classical case where we will prefer CT-based IV thrombolysis, do CT with angio. Even if you find a large vessel occlusion, do IVT and then you alert your MT team also that you are doing IVT, and if patient doesn't improve, they can consider that. This is another controversial issue when the patient has a dense hemiparesis, but by the time he reaches hospital, his hemiparesis is improved. So he has a minor non-disabling stroke. So whether to thrombolize these patients or not. So one option earlier was to just do imaging, do conservative management, find out the cause of his stroke. Now there is some guidelines, not guidelines, but recommendation from European Stroke Organization, their expert committee, that if these patients have a large vessel occlusion, you may thrombolize them even with a minor non-disabling stroke because they may progress. And the fourth scenario is a typical wake-up stroke. A 50-year-old lady wakes up with left hemiparesis, left gauge palsy, and altered sensorium. So in this case also you can guess because there is a gauge palsy and altered sensorium. So it looks like a large vessel occlusion. So in this case, MRI is preferred because it's a wake-up stroke. And if there is a diffusion and flare mismatch, you can do IVT. Suppose if you don't have MRI at your center, in wake-up stroke, you can still do CT-based thrombolysis. This is recommendation of TRUST CT trial published last year, that if aspect score is more than 7, you can do CT-based thrombolysis in unknown onset of wake-up strokes also. And then if you have special imaging, you can do special imaging and apply the radiological mismatch criteria of extend and diffuse because this patient may be a candidate of mechanical thrombectomy. Even if you don't have special imaging, you have DAWN trial, which has a clinico-radiological mismatch criteria. So this criteria can be applied and patient may be considered for MT. So this is the last patient. 63-year-old lady presented with seizures, altered sensorium, right hemiparesis. So this is her MRI. There is a large area of diffusion restriction here. And MRI was preferred because the diagnosis of stroke was not certain. Some ill health was there and patient presented with seizure. So MRI was preferred over CT. Now, if you see the diffusion images, there is nothing much is shown, but flare, nothing is shown. Diffusion has extensive restriction. And this patient has a large vessel occlusion. So this is a known onset stroke, not an unknown onset stroke, but you are getting a diffusion flare mismatch, but diffusion restricted area is quite big. So should we do something in this patient or not? I am just leaving it open for the house. Thank you so much.
Thanks, Dr. Bhutani, for the excellent presentation. As I said, we'll not have any questions now. We'll at the end of the session. The next is a very, very important session about the CT and MRI imaging and the aspect score. That is Dr. Anshu Mahajan from the Medanta Hospital. Dr. Mahajan, please.
चार्जर में लगा दें इसको ये चार्ज है तो छोड़ दीजिए एचडीएमआई हो जाएगी
So good morning, everyone. So today I'll be discussing about the most basic for the stroke management, that is the aspect score. We'll discuss about the aspect score, why it is needed. To begin with, this was a paper way back in 2000, which was published in Lancet, and they tested a quantitative CT score in predicting the outcome of stroke before the thrombolytic therapy, and they found those patients with a high aspect score with good functional outcome at 90 days, and they found this score to be very simple and reliable. So why do we measure the aspect score? So some physicians were very insecure in calculating or relying on the 1/3 MCA rule in that at that time. So this aspect score is very easy to calculate, which can be calculated by any resident in the emergency. It has a prognostic implication, and the aspect score of less than equal to 7 is a predictor for poor clinical outcome. So it can thus we can negatively affect the selection of the patients for the thrombolysis. So this score can be done for the anterior circulation as well as the posterior circulation, but it is mainly validified for the anterior circulation. It's a 10-point quantitative CT score. Let's see how we can calculate the aspect score on the CT scan. So the whole MCA territory, it is divided into different regions, and each region is given a score of 1. So there is a total score of 10. So the MCA territory is divided into subcortical regions, which includes the 4 areas. One is the, can we have a pointer? So one is this caudate. 1 point is given to the caudate. 1 point is given to the lentiform nucleus. 1 point is given to the internal capsular area, and 1 point is given to the this insular cortex area. So these are the subcortical regions which constitute the 4 score, and rest of the 6 score is basically restricted to the ganglionic and supraganglionic level in the cortical regions. So this is the M1 region, which is corresponding to the frontal operculum, the M2 region, which is corresponding to the anterior temporal lobe, and M3 is the posterior temporal lobe. And then we have the 3 regions which are above the M1, M2, and M3 at the superior lateral MCA territory level. That is above the M1 and M2 and M3. So these are M4, M5, and M6, also constitute the 1 point each. So this is the color illustrated picture. This is a caudate nucleus. This is the internal capsule. This is the lentiform nucleus. This is the insular cortex region, M1, M2, and M3. And we have M4, M5, and M6. So it's very important to interpret the CT images at a certain window. So we should always interpret the aspect score at a narrow window level. Look at the case example. This is the CT scan at a standard window, which is at 80 Hounsfield units and 20 Hounsfield units. We can hardly see any infarcts or hypodensity in any of the MCA region. When we reduce this window to a narrow settings, and we can appreciate a hypodense area in the posterior part of the lentiform nucleus as compared to the hyperdense area on the other side. So the narrow windowing is very important. So in addition to that, we should also know that the patient motion can also affect the aspect determination, and the final score may be sometimes subjective. It may be 3 versus 4, 8 versus 9. There is a lot of inter-observer variability. So if you are in a doubt, you can also add suffix like ish with your score. If you are not sure whether it is 3 or 4, but more inclined towards the 3, you can use the word 3-ish. So these are the few of the examples. So this is a case 1, patient. So patient presented with mild left-sided weakness, right-sided weakness. And can anyone tell in the audience that how much is the aspect score in the CT scan? So can we switch off the light? So we have to start from the subcortical levels. So so these are the area we have to identify: the caudate nucleus. It is hyperdense, so there is no hypodensity in the cardiac nucleus. There is no hypodensity in the lentiform nucleus. there is also no hypodensity in the internal capsule and the insular cortex. So the territory at the subcortical region is preserved. The 4 points are assigned, and now we have to see for the cortical regions. The M1 area, we have to see for the loss of gray-white matter differentiation. The cortex is always bright, and white matter is gray. So we have to see for the gray-white matter differentiation. So there is no hypodensity in the M1, M2, and M3 region, and also in the M4, M5, and M6 region. So the total score is 10. So this is another example. So sorry, the answer is already given. So how can we calculate in this? So the chordate is hypodense, so there is no hypodensity in the chordate. So no point is deducted. There is a hypodensity in the lentiform nucleus. The 1 point is deducted, and insular cortex. We can actually appreciate the hypodensity by comparing on the right side. Insular cortex is hyperdense, and it is hypodense on the left side. So 2 points are deducted, and then we have to see for the gray-white matter, loss of gray-white matter differentiation at the cortical level. So we can appreciate a subtle loss of gray-white matter differentiation, a kind of a evolving infarct in the M2 region and in the M5 region. So the rest of the areas are bright. There is an intact gray-white matter differentiation. So the total aspect score here is 6. So sometimes, and this aspect score is not reliable in the NCCT scan. We have seen in few of the cases, like this is the paper which has already shown that the CTA source images predicts the aspects predicts a better outcome than the NCCT aspects. So we can see that this is a case example. So we encountered a few months back a 43-year-old female who had a stroke on the right-sided weakness, aphasia. Her NHS score was very high. The window period, he came within the window period of around 8 hours. So can anyone tell me how much is the aspect just roughly on the CT scan? It's just a static image at one point. Only on this image. So we have to, yes. So it's not a chordate nucleus, it's a lentiform nucleus which is gone. But otherwise we can, as compared to the right side, we can still appreciate the bright cortex on the left side. But when we interpret the CTP imaging, this is a CT perfusion maps. This is an MTT map, which is showing a large area of hyperperfusion. There is an increase in the MTT, and there is a decrease in the CBF. These are the CBF maps. And this is a CBV map, which is actually corresponding to the diffusion map. It actually shows if there is a low CBV, that means the area is already infarcted. So this area was already infarcted. Then we readjusted our CT source images windows to a low level, and then we reevaluated the images, and we can see that there is already an established infarct in the left MCA territory, and there was an MC occlusion. So should we thrombolize these patients? No. So sometimes the NCCT can be unreliable. So with regard to the use of the CTP, aspects with the CTP, the data is very ambiguous, and it's not very it is not having a much advantage over the NCCT. And if we have to consider with the diffusion MRI, it's much more reliable, much more it is having a much more sensitivity. And in most of the papers, the interrate observer is more inclined towards the rate is more inclined towards the MRI. So if we have to follow the AHA guidelines, which was in 2018, and this was updated in 2019, and the patient should receive a mechanical thrombectomy if the aspect score is more than 6. So does this mean that all the patients with aspect 6 are excluded from the EBT? I think no, because the MR clean, which was the trial, which it did not depend on the aspect score, it only depends on the LVO. And even in the post hoc analysis, they revealed that the good outcome of the EVT in a patient with the aspects of more than 4. So the aspects, it can guide only the treatment decision. So we cannot completely rely on the aspects to guide the mechanical thrombectomy treatment in all the patients. So we are coming up with the few papers. This is from the Japanese journal, and they have shown that basically they have done a mechanical thrombectomy and endovascular therapy in a patients with a low aspects, with a large established infarct. So what they have compared, that they have compared a better functional outcome in those patients who received endovascular therapy as compared to those patients who have received medical therapy. But these patients were associated with more intracranial hemorrhage. So similar to the anterior, we are doing the aspects in the anterior circulation. We have aspect score for the posterior circulation also, but it is unreliable. They have done on the CT scan or also on the MRI scans. So here, what we do is the 1 point is each given to the thalamus, both the thalamus and both the cerebellum, and 1 point is each given to the PCA territory, parieto-occipital area. And the 2 points are assigned to the midbrain and pons. So if the midbrain is involved, the 2 points are deducted from the total score of 10. So this was the aspect score paper on the posterior aspect score paper on the using an MRI scan, but it's totally unreliable. We always use a criteria of the involvement of the pons. If it is the pons in the involvement is more than 50%, pons or midbrain involvement is more than 50% in most of the patients, we don't usually offer these patients any form of endovascular therapy or medical therapy like IVTP. So the take-home message is aspects is a useful tool to communicate the scan findings, but it is well validated in the anterior circulation stroke, but not for the posterior circulation stroke. If you are in confusion, you can use the ish, you can add a suffix ish to your score. This is, thank you.
You can kindly, whatever questions you have, please send them across to us, because that will take at the end of the session. Thanks, Dr. Mahajan, for an excellent talk. Can I now call upon Puneet Agarwal to speak about IVT and bridging therapy?
So good morning, everyone. First, I'd like to give thanks to Dr. Arun and his team for organizing a wonderful conference and for inviting to speak on one of the topic of my area of interest, that is this IVT, that is a thrombolysis treatment, IV thrombolysis treatment. So I'll basically speak on IVT as well as a bridging therapy, and about the current guidelines, which is really, I think Dr. Anshu, Dr. Renjen has rightly said that recently updated and Dr. Bhutani has also mentioned that in 2019. So this is a classical CT angio usually we get in patients of acute ischemic stroke, and many times you are confused whether you have to thrombolize, even if the patient coming from in the window periods, like left MCA 10 sign, and angio is showing left MCM1 occlusion with the poor collaterals, whether you'll go for the IVT or bridging therapy. So I'll speak on that. And with the advent of advanced neuroimaging techniques, which Dr. Anshu has elaborated right now, and Dr. Renjen also, that CTP, which is, we have a rapid software in our hospital in Max, so we are doing CTP in some of the selected cases. So where you can see the mismatch between the core versus the ischemic penumbra. So aspect score has already been discussed. And this is a certain selected case we require MRI to be done in acute ischemic stroke to know the in which there is a diagnosis in confusion or patient coming after window period. In those cases, you can do the MRI, you can do the MRI perfusion scan also. So we're doing in some cases, we have done out of window period from the mechanical thrombectomy, similar to Dawn trial, and in 3 patients till now using the MRI and MRI perfusion scanning. So this advanced imaging has definitely changed the scenario and has increased the window period from the 6 hours, which is till now, to the 24 hours now. So the other recent various trials which were done, and for the imaging, using imaging biomarkers to extend the window period, like for the IV thrombolysis, ICAS-4 extend trial using up to 9 hours window period for IV thrombolysis. They have shown some favorable response in selected group of patients. But basically for the mechanical thrombectomy, dawn and diffuse trial definitely are landmark, very good designed randomized trials, and which are led to the FDA approval also that we can do the mechanical thrombectomy up to 24 hours in selected group of patients. Now, coming to the guidelines, which are recently, till now, the recent is 2019 guidelines for IV thrombolysis. And so our evidence says that we can do the IV thrombolysis in patients with the altiplase or RTPA. There is a class 1 level A evidence in patients who are coming within 3 hours with a ischemic stroke. If he is fitting into the eligibility criteria, there is no contraindication, or you can also thrombolyze up to 4.5 hours. IV thrombolysis can be done. There is so for the 3 to 4.5 hours, there is a class 1 and the randomized B level BR evidence is there. And recently a newer drug in last few years have come is a tenecteplase, although it's an old drug used for MI for many years. But in case of acute ischemic stroke, it has a class 2B and level BR evidence of doing IV thrombolysis within 4.5 hours in the eligible patient, if in alternative to the TPA. And in India, it is a Indian Stroke Association has approved to use it within 3 hours in the dose of 0.2 milligram per kg. So patients, in patients, so there are certain odd patients in which you have certain which are not the classical case for thrombolysis, patients having a higher blood pressure. In those cases, you can still thrombolyze. The criteria for blood pressure is that it should be less than 185, 110 before the thrombolysis, and you can manage with using the IV injectable drugs if it is high. And patients who are after thrombolysis, the criteria for managing blood pressure is that should be kept between less than 185, 105. Patients who are on single antiplatelet drugs, there is a class 1 level A evidence that you can thrombolyze these cases without any problem. And even the patients who are having dual antiplatelet drugs, there is a class 2A evidence with a level BR evidence that you can thrombolyze these cases with IV thrombolysis if they are eligible and there is no other contraindication. Now, this is very important. The patients coming with the end-stage renal disease, in those cases, so normally it is said that you require a blood sugar to be done nowadays for doing a thrombolysis before IV thrombolysis, although you withdraw the blood for other things, but you don't wait for other lab samples to come except the blood sugar, which should be more than 60 milligram per cent, or if it is less than 400, it should be corrected before going for IV thrombolysis. But patients, special cases who are having coagulopathies, patient of CKD and end-stage renal diseases, in those cases you require a APTT to be seen, and if it is normal, then there is a level class, there is a class 2B evidence that you can thrombolyze, IV thrombolyze these cases with slightly increased risk of hemorrhage, but there is indication you can thrombolyze, weighing the risk and benefit in those cases. Even in patients who are doing on dialysis and without any reduction of the IV TPA doses, people have done 0.6, they use a 0.6 milligram per kg also TPA, but it has not shown any extra benefit. Now, certain other patients who are initially not taken for IV thrombolysis, as we have discussed earlier, like seizure at onset, patient having pre-existing disability, or patient having coagulopathy. So in those cases, you have to wait to come for the platelet count, PTNR, APTT report to come. And if it is normal, in those cases, there is a class 2B evidence with level CO that you can thrombolyze, weighing the benefit and risk and discussing with the patient. Patient who are having the lumbar puncture has been done, or arterial puncture has been done in last 7 days. In those cases, again, there is a class 2B evidence with a level CLD that you can thrombolyze these cases, again weighing the benefit and the risk. The recent major trauma within last 14 days, there is a class 2B evidence. If there is no intracranial bleed and there is no other contraindication for thrombolysis, patient is eligible. So weighing the benefit and the risk, you can thrombolyze with caution. Regarding the recent major surgery, According to the recent guidelines, there is a class 2B evidence that patient surgery done with weighing the bleeding from the surgical site after discussing with the surgeon, if weighing the benefit and the risk can formalize with the class 2B evidence and they will CLD that in these cases. Otherwise, patient having large vessel disease, a mechanical thrombectomy, direct mechanical thrombectomy can be done if there is a risk of having a local site hemorrhage. Patient of GI bleed definitely is one of the there is a more chances of having a more harm than the benefit. But patient having a genitourinary bleed, there is a class 2B and level E evidence that level CLD evidence that you can thrombolize these cases. Patient having a menorrhagia, in those cases, the thrombolysis should be avoided because of the increased hemorrhage, increased bleeding. But patient with normal menstruation, there is a class 2A evidence that you can thrombolize these cases. Now coming to dissection, which is again important, patient having a extracranial dissection, there is a class 2A evidence, and we have also thrombolized in practice that in those cases with a level CLD evidence that you can thrombolize these cases with IV thrombolysis. But patients of intracranial dissection, there is a class 2B evidence. So there is a slightly more risk of, if you weigh the benefit and risk of doing a hemorrhage in these cases. Now coming to MI, the patient having acute MI with a acute ischemic stroke, you can thrombolize with the class 2A level CLD CO evidence that, and then later on patient can go for the primary angioplasty. Patient with a decent MI, as Dr. Bhutani has said, that patient of non-STMI or patient having a right side myocardial involvement, in those cases, even if the MI is in last 3 months, now it is shifted to the 2 weeks now. In those cases, you can thrombolize, but patient having involving the left myocardium, we have to be cautious because sometimes it can lead to a ventricular rupture. So in those cases, you have to discuss with the cardiologist, and if their disability, if you're finding that advantages are more, then you can go with a caution. Now, patient of systemic malignancy, ophthalmic condition like diabetic retinopathy, hemorrhage, you can thrombolize these cases. Again, there is a class 2 evidence you can thrombolize, but with caution in these cases if there is no other contraindication. Patient having a stroke mimics, as Dr. Renjen has said, that in those cases, there is a very low incidence, has been seen that studies have shown there is low incidence of having there is a harm to going to the patient, giving to the patient. So there is a class 2 evidence, and stroke mimics, if you have thrombolized with your all the criteria meeting, then there is usually there is no harm. It doesn't mean that you should thrombolize these cases very frequently, but if you sub many lymphoma many times is a mimicker, in those cases people have thrombolized all over. Now patients who are having a early improvement, as has been told earlier, so in those cases you can thrombolize, though if there is a residual damage, residual disability is still there, or patient having a mild stroke but having a disability like having a vision loss or hemianopia, or patient having a hand weakness with even with a mild NHS score less than 5, in those cases because it's a right hand affected or a vision loss is there, then you can thrombolize these cases. Now patient having aneurysm, this is a tricky condition, patient having aneurysm which is unruptured, having a less than 1 centimeter size. In those cases, there is a class 2A evidence. You can go with the IV thrombolysis, again with the caution because hemorrhagic transformation may occur and it has to be discussed with the family members, then you can go for that. Patient with the AVM or CMB, cortical microbleeds more than 10, in those cases chances of hemorrhages are much more after IV thrombolysis, so you have to be cautious while doing the thrombolysis. Procedural stroke, so patient having a procedural stroke, in those cases like after angiography, so that's very common, IV thrombolysis can be done in those cases with a level class 2A evidence. Now there is a standard contraindication, I'll not go in detail about that, but if CT showing hemorrhage, time is more than 4.5 hours for IV thrombolysis, patient coming with a stroke within 3 months, again it's a relative contraindication, not absolute one, except the hemorrhage, which is an absolute contraindication on CT, all other relative contraindications. Patient having even ICH nowadays, if it is very old, it's a small one in the past, no AVM or no aneurysm, you can thrombolize these cases with a caution. So patients in a coagulopathy, patient has taken a low molecular weight heparin within 24 hours is again definitely one of the important contraindication. should not thrombolize. Patient taking now this is a direct thrombin inhibitors, like a lot of nowadays we are using a Pradaxa, or we are using a dabigatran, or we are using a rivaroxaban or other direct inhibitors very frequently in AF with a stroke. In those cases, the patients, if has missed the dose 48 hours before coming to the triage, and onset of symptoms are after 48 hours of missing of the dose. In those cases, if the coagulation parameters are normal, like especially the APTT as well as the platelet count, then you can thrombolize these courses. IV thrombolysis can be done in those cases. But patients who have taken the dose within 48 hours, in those cases, we have to do all these coagulation parameters. We don't have facility to do the ECT or thrombin time, but we can do the APTT, we can do the platelet, we can check it out. And if there is no evidence of any bleeding and patient taking dabigatran, we have a reversal agent idalizumab, which can be given in those cases, followed by thrombolysis. Now, I'll not go in detail about that. The only thing is brief about tenecteplase I've told you. So tenecteplase is used FDF to Indian Stroke Association has approved dose of 0.2 milligram per kg versus in the doses in the patients who are coming within 3 hours. All those studies have shown that people have used it in patients who are for acute stroke. So in 2015, there was a class 1A recommendation has come for mechanical thrombectomy in patient with acute stroke, and these are the standard guidelines prerequisite for doing a mechanical thrombectomy. NHS score more than 6. These are the candidates for doing a mechanical thrombectomy. And why the question of only mechanical thrombectomy, not IVT? Because there is accumulating experience that proven effectiveness of MT even in patients with the IVT contraindications. So that led to the belief that we can do only with the IVT mechanical thrombectomy instead of going with the bridging therapy. And there are certain unfavorable effects of bridging therapies have been found, that the bridging therapy can lead to a delay in the treatment, can lead to the hemorrhage transformation with worsening of the stroke. Points which are or that might not for the direct medical thrombectomy. There are 6 landmark papers have come which have solved this issue better. Is published in 21, SKIP trial by from Japan, DEV trial from China, Emma Clean from Canada, Swift Drive, Direct and Direct Safe, and I have come, and which are, so I'll go and brief about those to solve this issue. So this is a direct MT trial which is done in China. It's a large trial of 656 patients done in 1:1 ratio. It's a randomized trial, endovascular thrombectomy versus the bridging therapy. It has been found that direct MT is non-inferior it was found non-inferior to the bridging therapy. So it was favoring the role of direct MT basically instead of going for the bridging therapy. And there's a DEF trial, again it's a Chinese trial, and on 116 patients of endovascular thrombectomy and 11 patients of bridging therapy, it has found again a non-inferiority that it proves that endovascular treatment alone compared with the intravenous alteplase plus endovascular treatment met the prospective statistical threshold for non-inferiority. Now, if you see the Japanese trial, SKIP trial, it failed to show the non-inferiority of direct MT versus bridging therapy. And it was done in recently, it has been again recently published, done in 204 patients. There is another very good trial done, this is MR Clean trial on 539, good number of patients, a randomized trial, which has shown that EVT alone was neither superior nor inferior to the IV bridging therapy. If we are seeing the MRS score within 90 days, So it favors the role of bridging therapy as compared to direct MT. And there is a SWIFT direct trial which is recently published from Canada in 22, and which has shown that thrombectomy alone was shown to be non-inferior to IVT plus thrombectomy and resulted in decreased reperfusion rate. The direct SAFE trial again favors the role of bridging therapy versus in comparison to the direct MT, which is again recently published in 2022 from New Zealand. So if you see all these trials, you can see except the direct MT and DEP trial, which are against the bridging therapy, all 4 landmark trials, which are very good trials, have shown that they favors the bridging therapy, to go for the bridging therapy, and then followed by, so IVT followed by mechanical thrombectomy should be done in all these cases. Now, so there is a 2019 AHA recommendation that patient eligible for IV thrombolysis should receive IV alteplase even if mechanical thrombectomy is considered. There is a level A and class 1 evidence now. And European Stroke Organization has also approved the same thing recently about the same which as AHA has recommended. So the data has shown that patients where the thrombectomy care center facilities are available, in those cases, patients should go with the IVT followed by mechanical thrombectomy. And where these facilities not available, patients should go for the IVT, and patients should be transferred for the center where the mechanical thrombectomy facilities are available. So why this benefit is there with doing the IVT, although there is a delay in the treatment of MT? Because it has been seen that intravenous thrombolysis allows immediate administration of potentially beneficial reperfusion therapy, and it also leads to the certain reperfusion. It prevents the reperfusion injury which is done by the MT later on, or certain residual thrombus which is remaining even after MT, maybe lies by doing a IVT before. So the other different advantages. That's why this IVT treatment, the bridging therapy is better than the doing a MT alone. Thank you.
Puneet? Puneet? Next. Please, next. Number 2. Yeah, on thrombectomy.
MT.
Ah. ये thrombectomy पे है ना, identifying patients.
आपको पढ़ा है?
सेकंड वाला लेक्चर दे दो. Good morning once again. I'm back here. After all the beautiful lectures that you've been having till now, I'm to talk about identifying patients for thrombectomy. Of course, Gaurav is here, and obviously the neurointerventionists are more enthusiastic about it. We are even, but I suppose it's a prime duty to identify the right type of patients who require thrombectomy. Now, the early management of any ischemic stroke is rapid identification, we've just talked about, immediate transport to the nearest stroke center, standard care IVTPA within 4.5 hours of stroke treatment, and mechanical thrombectomy with patients with large vessel occlusion within 6 hours of stroke onset are obviously something which are very, very clear and worked up. The endovascular therapy, or the EVT, is the standard of care now for patients with acute ischemic stroke due to large. When I made a standard of care, what I do in Apollo is that when the patient comes, he was going to give him TPA. On the same stretch, he has a CT angio right there, so that if he requires a thrombectomy, he can shift it to the DSL lab in our hospital, which is very close to the emergency. IV TPA should be administered. That's my own view. Puneet may differ with me, But I think IV TPA should be given to all eligible patients who are being considered for EVT, and neither procedure should delay the other. So in our hospital, after reading all the literature, attending all the conferences, I'm pretty convinced that IV TPA should be given, and then the patient should be handed over to Gaurav for doing the thrombectomy. And I can tell you one thing, all those sitting here, you have to be really, really enthusiastic. You got to be really with it. And that is why I'm so impressed by some neuroradiologists, especially in Calgary, by Gaurav Goel. I mean, they just at it. And you have to also be at it. That yes, look for a patient who requires a thrombectomy. LVO patients can be identified using non-invasive vascular imaging study. If these are not available, NIH score can be predictive of a large vessel occlusion. So your aim has to be 3.5 hours, 3 hours, 4.5 hours. Patient is in your triage, thrombolize, see if you can give this patient to your interventionist colleagues. Despite the overall benefit of RTPA, the subgroup of patients with large proximal intracranial vessel occlusion, carotid proximal middle cell, have low rates of recanalization, which we all know, with thrombolysis, and only a 25% chance of good outcome, which is bad enough. So I would prefer that, yes, I have a patient who has a large vessel occlusion, I thrombolize him, and I send him to my colleague to do it because I know he's going to do better. Endovascular thrombectomy, in addition to the best medical treatment, has been proven in 9 randomized trials superior to best medical therapy for patients with anterior circulation, large artery occlusions. I would just touch upon the posterior circulation, which Gaurav has a vast experience, he won't, I don't have much. Interestingly, the number to treat and achieve a reduction of 1 or more points on modified Rankin scale is 2.6. Fantastic. What a great thing. Number to treat, that means if you treat 2.6 patients, 1 out of these guys is going to benefit. So what are statistics to have for thrombectomy patient? Now, what are the AHA, ASA recommendations? We all go by AHA, ASA recommendation because these are really the guidelines for all of us. Emergency non-contrast CT imaging of the brain is recommended before any specific stroke treatment for acute state. I will go a little further. In my unit, believe me, I don't run after MRI. I depend on a plain CT and a CT angio. MR takes time, more time consuming. And number 2, why should every patient of acute ischemic stroke have an MRI? I'm sure Gaurav, Puneet may not agree with me, or they agree with me, I don't know. But I think it's only when you have a stroke, which doesn't fit into a stroke, which we just said stroke, chameleons, we talked about stroke mimic, there's something unusual about this stroke. Please go and do an MRI, that's what I do. Patients eligible for IVTPA should receive IVTPA etiplase even if medical thrombectomy is being considered. Just one short one. Is etiplase superior to tenecteplase in patients who get IV therapy and then go for thrombectomy? There has been one study which did show that tenecteplase patients did comparatively better than etiplase patients. So I are more going towards tenecteplase because I think that agent is good, short acting, fast, can be given faster. For patients who otherwise meet the criteria for mechanical thrombectomy, Non-invasive imaging of the intracranial artery is recommended during the initial evaluation. Patients should receive thrombectomy with a stent retriever if they meet all the criteria. What retriever they use, none of my business. I'll just hand it over to Gaurav. What he uses, what he does is none of my business. My business is to pick up the right patient and hand it over to my intervention colleagues. To ensure benefit of reperfusion to TICI grade 2B3 should be achieved as early as possible within 6 hours of stroke onset. So these are the basic guidelines which you must stick to. Now, class 1 recommendation. Decision-making criteria for mechanical thrombectomy, 0 to 6 hours. Within 6 hours of stroke onset, pre-stroke workup, carotid occlusion, and treatment, and by that Goel procedure can be done. The use of mechanical thrombectomy with stent retrievers can be reasonably good for selected patient awares whom treatment can be initiated within 6 hours and who have positive occlusion of the MCA 2 or pre-stroke MRI score of more than 1. What happens if you cross 6 hours? Can you do something? Do you want to do something? Or you want to say, chalo bhai tera kaam ho gaya? No. I think uska kaam nahi hua. That's why I say you have to be pushing, pulling till the time. So in selected group of patients with acute stroke, 6 to 16 hours of last normal of LVO in what Puneet mentioned were the two most beautiful study which anybody who wants to do stroke should read, the dawn and diffuse. In selected group with the AIS, within 6 to 24 hours of lost normal onset, which LVO and interior circulation meet other dawn eligibility criteria for mechanical thrombectomy is also reasonable. So, 6 hours, then you got to 6 to 16 hours, 24. So please be on your toes. Let your team be on your toes for these patients. I'm not going to go into the details. Puneet has mentioned the dawn trial, but I think it was one of the very nice trials, and all of you should really read of it because the passage of time, we are already, I think, little short of time. This is the diffuse, which again I will also talk to. To summarize, again and again, age, severity, plain CT, pre-stroke functional status, and the time window should be the criteria for mechanical thrombectomy. Posterior circulation, just few lines. I feel very bad about posterior circulation strokes. At time you got a top of the basilar artery syndrome. He's a man of 45, 50, 55. He's conscious. And you go 6 hours later, you get a call that he's no more. The mortality in posterior circulation stroke is 70 to 80%. So are we going towards thrombectomy in top of the basilar artery? Yes, we are. And I'll show you a recent trial in a little later. Now, there was no difference, usual things. Actually, this was the basic trial. Now, I just show you this picture. Empty in posterior circulation stroke. You've got the BSI, basics, the BROSH, and the attention trials. None of them were convincing. But this was a recent trial. A perfusion imaging predicts favorable outcome from basilar artery thrombectomy. Now, in these trials, these guys did a perfusion scan. And there was some area which was reperfusible. They did a thrombectomy. And if I remember the exact percentages, 25 to 30 or 35% did quite well. Now this I would like Gaurav to comment, because I don't have any much experience with posterior circulation stroke, but I want to do more of posterior circulation stroke to do it. So the conclusions are very, very simple. Mechanical thrombectomy is the answer. As far as I am concerned, give TPA, do mechanical thrombectomy, and for 6 to 16, follow the criterion as it is laid down. Thank you very, very much for a patient hearing. And the next speaker is a great friend who has got a large experience in medical thrombectomy. So, Gaurav, wherever I've gone wrong, please do correct me. You're not gone wrong anyway.
So I think let me just summarize the indication is you should have more reasons not to do it than finding out reasons to do it. That's the crux of stroke management these days, whether you are doing IV thrombolysis or you are doing mechanical thrombectomy. Okay, it's fluctuating. It's fluctuating. Okay. Okay, we have a problem. Yeah. This doesn't work. Got it? Okay, so we're here. So next 15 minutes or so we're gonna talk about the mechanical thrombectomy, and this is typically what we want to say. Although a lot of things have been covered by Dr. Renjen and Dr. Puneet here. So guidelines, now we know that when we should do it. I think we just heard extensively about the guidelines. So the only thing is where I want to add is you should not keep waiting. Like if you have given TPA, you should not wait. And we work like on a pit crew model, and I think for every stroke call, an interventional radiologist, neurointerventionist should be called, and he should be part of the decision making process. And it should work in parallel rather than in series, that you do a scan, then you do thrombolysis, then you give him a call, then he comes, he analyzes, then decide, then lab. It should happen as the patient hits the door. Everybody gets to get involved there, because our goal is to achieve recanalization, complete perfusion as quickly as possible, and this is what is going to lead to a better outcome for these patients. So the best case scenario is going to be a good patient, a young patient with a favorable anatomy, aspects as shown by Anshu, that it should be a good aspects of more than 6-ish, and there has to be a large vessel occlusion. So bad patient, good imaging, do whatever you want. CT perfusion. We do CT angio CT perfusion in our center, but even if you are able to do a rapid MRI, that's fine. And this is typically the time frame, and I'm sure everybody has seen a lot of these slides where there is a large vessel occlusion. We go in with a stent retriever or an aspiration catheter and try to plug out the clot as quickly as possible. Most important is to find out when not to do it, and this is the same slide which Anshu showed. So we look at all these criteria, that and it's done very quickly. It doesn't take a lot of time if you are doing repeatedly. That if there is a bad aspect score, there's no mismatch between your CBV and CBF, we should not do it. And we generally do not like to rely just on CT alone when we have to make a mechanical thrombectomy decision. For TPA, we are fine. But for mechanical thrombectomy, we like to have either an MRI or a CT perfusion to guide us. So because everybody is different, if there are poor collaterals, the time window won't help you that much. So we do not want to have a futile recanalization where we went and we opened the artery, but the patient didn't do well or has a bleed. So even at 5 hours, patients can have large infarct. So make sure we sort of optimize the treatment and correct it. Though more and more data, this is the pooled Hermes analysis data, which is showing that, even if you start doing in aspects of 3, 4, and 5, there is benefit to the patients. Only when you go down to the aspects of 0 to 2, which means practically everything is gone, then the benefit is lost. So I think guidelines I'm just gonna skip. We should have a stroke team, and this is how we should do. Everybody should work simultaneously and have a protocol in place. So this is our protocol, that we have a stroke code. So the moment the patient hits, right from the doctors to the GDA to the security lift person, everybody gets involved. So there are no delays, and we are able to do it as fast as possible in the Indian scenario. So everybody knows what to do, when to do, and as Dr. Renjen said, most of the time the patients will be thrombolized on the CT table if financial and other considerations are okay. And advanced vessel imaging is absolutely essential. So one form or the other, choose your own protocol, what you like, whether it's CT based or MR based, it doesn't matter. And okay, there's something wrong. Yeah. So for longer duration of period and dawn and diffuse trial, it's better to have those advanced imaging than not. We use extensively social media platforms to our advantage. WhatsApp is a boon. Most of the time the fellows will send all these information and scan at the middle of the night, and it's easy for you to make these decisions. So coming to the procedural details, we are evolving as everything. So from stiffer catheters, stiffer wires, to newer guiding catheters, newer stent retrievers and aspiration. And we as interventionists, we keep debating and talking about which technique is the best. Doesn't matter as long as you are getting the outcomes. So typically, the stent retrievers were the first one to arrive on the scene for a successful thrombectomy, where you will just cross the clot using a microcatheter and wire. And once the clot is crossed, we use what we call a self-expanding stents. So these are different from coronary stents, as you know, and they will expand. The clot gets engaged into them, and after waiting for a certain period of time, ranging from 3 to 5 minutes, which you give for the stent to engage more with the clot, you try to pull them out. And more often not, you will find that even in the first pass, almost in 60 to 70% of the patients, just doing this simple thing can pull most of the clots out. And it has been now shown in 9 randomized controlled trials that it do work very well for these patients. So I'm just waiting for a second where we're gonna pull this out. We inflate a balloon guiding. We don't do this anymore, but I'm gonna show you what we do it. But this is a good animation to demonstrate how these things work. Okay, so we also try to play around with stent retrievers, that we try to fluff them so that they engage with the clot more. So chances of clot coming out in the first pass is higher. And there are studies which have do the quantification, and this is most common push and fluff techniques which we use with stent retrievers. Then of course the other method is aspiration, that instead of using a stent, you can use a large bore catheter, which is almost the size of a guiding catheter, but they are very soft and flexible, and they can be advanced up to the interface of the clot and connected to a suction vacuum, and the clot can be sucked out. And the most common which we use in our place is a combination, where you are using the power of the aspiration catheter to pull it out, and also stent retriever to engage it. So you are throwing the kitchen sink at the clot and say, this is all what we have and this is all what we will do, so that we can get the clot out at the fastest. We have 1,000 variations of these techniques now. Everybody has a different name, whether they are using the balloon guide in association, which guiding catheter, which stent, whether aspiration at one end, aspiration at both ends. So numerous technologies. So we decided we will also call our technique with the name. So this is what we call DAF. It's a dual aspiration and fluff technique. So for the steps of it, as we seen, we will cross the clot and place a stent using a fluff. That means we are pushing on the stent retriever so that we get more clot integration. Then we have aspiration catheter, which will be taken up to the point where the clot is, so that we are actually pinching the clot. I don't know if this is going to work. Yeah. So here you can see this is the aspiration catheter sitting into the M2, and this is your stent retriever, which is barely seen. So it's pinching the clot right at the stent retriever, and then you are aspirating it at the both ends. So you are aspirating it at the aspiration catheter, and some debris may also come in the guiding catheter. So you are also aspirating it there. So these are the dual aspiration pump we use to aspirate at both the end. The clot is really stuck at the aspiration catheter and stent retriever, which is pinching, and this is eventually pulling out of the entire assembly in one go, and hopefully the clot comes out. So with this, our first pass rate jumps to almost 90% plus, and except for the most adamant and hard clots, most of the time we are able to get the clot out in the first pass. So do we have a final answer? No, because the world is divided. So we have aspiration stents, combinations. Most of the trials do not prove that the combinations work better than the aspiration or stent retriever, because even with these techniques there is a learning curve. There, every operator will have a different way of doing it, and so I think we are still far away from having a standardization among ourselves. For large vessel occlusions, as we discussed, we have good guidelines even for patients above 80 years. We have meta-analysis, pooled analysis, which lead to these guidelines. And I'm just skipping it because they have been talked about at one point, which is not that both aspiration and stent retriever works. So whatever you are more comfortable with in your setup, you can choose. If you are using a combination like us, it also works well. So from six, dawn and diffuse has been covered. We can skip that. The guidelines also do touch upon extending the envelope for small vessel, distal vessels, aspects of less than 6, or posterior circulation. So few case examples. We always do, as you see, this is our standard CDs of CT angio, CT perfusion, demonstrate penumbra, demonstrate a large vessel occlusion, go in, and this one is just by the stent retriever. So I'm going to show you the spectrum. So microcatheter is crossed, stent retriever in place, balloon guiding inflated, and of course, since I'm showing you, it will be first pass always. The artery opens up well. That's the CT scan with some patchy infarcts, and patient do well at discharge. Same things can also be done just by using an aspiration catheter. In this, you take a large bore guiding up, aspirate out the clot, and this is the point where I think the bridging really helps, because whatever you do, it's not always a ticky 3. You will always have some distal emboli which may have happened during the initial insult or while you are trying to open them up. And if these patients are thrombolized, I am very comfortable because I know at least for these distal occlusions, these TPA is going to work. So I think that's the role for the bridging which comes up. And we are very pro, like if these patients are eligible for TPA, we never say no, but we do not wait also. So and most of the times nowadays, and we have neurologists as our fellows, and we keep wondering because sometimes we have opened up the artery and the TPA is still going on. So the question is this, like you have started with 60 milligrams, let's say, you have given a bit, half is still left, artery is open. Should we continue? Should we stop the TPA? We don't know the answer. If you do know, please let us know. So that's the Solumbra technique, and this was the index case which we did. So posterior circulation, P1 and basilar top. We tried aspiration, we tried stent retriever, nothing was working. So we advanced the aspiration catheter like we do for Solumbra, and then the clot comes out at one pass. So we realized that, instead of making it like a failed sort of a rescue therapy, why not make it a first go? And since then, for last 5 years, this is what we are doing for all cases, that single pass, use both techniques. And these are cases after cases for the similar technique. And in interest of time, I'm just running by, but I think you get the gist that how we do it. So most of the times it's fine. So I'm just going to skip these few cases here, and come to the last part of no, not second last, tandem occlusions. So in India, we see a lot of patients who have got carotid artery stenosis, dissection, occlusion, along with a middle cerebral artery occlusion. And guidelines again say that we can treat these tandem occlusions. It's reasonable to treat them. You can do an emergency stenting or endarterectomy, with a caveat that there should not be a free floating clot into the artery, and there should not be a large infarct already. There should be a significant penumbra for you to do that. Now the question is, which one you should address first? Should you stent here first and then go up and open up the artery, or just go through this artery, open up the intracranial vessel, and then come back and do this? So it's an antegrade versus a retrograde approach. The advantage of antegrade is, of course, you're going to have a more smoother path to go up into the brain. You can restore the extracranial flow, less chance that you will throw another clot later on, but then you are not opening the brain artery, so you are losing that time period. So this is the proximal to distal approach. Again, literature is divided. We have some data coming out in favor of antegrade approach too, but this is the initial patients. Now we have stopped doing this. We have shifted more for retrograde approach now, because we think brain is more important. So we just bamboozled our way through the occlusion, go up, or maybe just do a small plasty to create a path. Once you are up, then you can open up the brain artery and then come back. The disadvantage is sometimes when you come down, they throw another clot and you have to repeat the whole cycle again. That's a disadvantage. But again, we have good data coming out that this is safe and effective, and this is typically what we do. You see a complete occlusion, you just go through it, open up the artery, then come back and use your standard carotid stenting techniques to place a stent. The advantage sometimes is that you may actually avoid a stent if it's not required. So like for this 80-year-old gentleman, he had a common carotid artery occlusion. So we went up, digged our way through it, and once we have opened the brain artery, when we came back, we just did a plasty at the origin, not doing a stent, and that just worked. So we avoided antiplatelets, we avoided a stent in the acute stroke situation, just because we didn't want to leave this channel open that way. So I think the bridging part has been covered, so I think I can just skip it. And anesthesia, it's controversial still. So should we give general anesthesia or should we do it under local? Again, the advantage and disadvantage of losing time, losing collaterals as we give anesthesia, patients may go into hypotension. But most of the times, if it's a cooperative patient with a right-sided occlusion, we tend to do it in the MAC. If it's a left-sided posterior circulation, patient is very restless, then there's no point struggling with that patient, then we should go for general anesthesia. Do tell your anesthetist all the time that there should not be a hypotensive episode. Most of the time they come from general side if at night, and they do not know the importance of avoiding the hypotension. Intraarterial Riopros, if required, can be given if TP has not been given to these patients. If TP has been given, then you may have to just give intraarterial TPA. We do not succeed all the time so easily. So there are certain lesions which are difficult to treat. They're adamant, and this is one of these patients. Typical looking middle cerebral artery occlusion, no clues whatsoever that there is an underlying admin clot, good penumbra, patient rushed to the lab. We found an M1 occlusion, crossed it, did the standard thing, videos running, okay. So artery seems reasonably okay, but probably an ICAD underlying, and it's starting to close off very quickly. So we opened it up again, same situation, and after multiple passes, we decide to place a stent because we know it's an ICAD, whatever we do, it's gonna close off soon. So we place a stent, the stent also will start to close off because you have not given antiplatelets. So you need to open this up, give epciximab, keep them probably on the infusion for few hours till the time the antiplatelet effects kick in, and then you are able to achieve the recanalization. So I have not kept very difficult cases, but we do get these ICATS association where we have to place these stents. And now we are moving further and further into the brain territory. We are moving into more of M2s and M3s and P2s. So these are also important vessels, and I think the safety is coming up. Trials are going on, and we should have trials soon. So distal M2 occlusions, we have smaller micro catheters and retrievers, not the standard ones, but the smaller ones, micro ones, which we can safely track around all these angular branches, pull out the clot, and have good outcome of these patients. Posterior circulation, similar thing. Sometimes when you are opening up the basilar, the clot will migrate into one of the PCAs, and it's an important artery of the brain. So again, you change your devices, switch to smaller retrievers, and you can open up these vessels. Same thing for anterior cerebral artery. It controls the power of the leg, which is important, and you can use these devices to open up. Okay, do we succeed always? No. So sometimes we make a mess of it. So when you are over jealous, this patient, we tried opening a distal vessel. We went in, we deployed the stent retriever. While we were pulling it out, we ruptured the artery. So you can see the extravasation of the dye which happened, and eventually we ended up gluing the same artery which we were trying to open because the artery is ruptured. So not always you will be lucky. So sometimes you will have that. So since we closed it immediately, there was no major significant thing. Patient ended up with the same deficit with which he arrived, but it's a caveat that we have to be careful. Sometimes the roots are blocked, because these are all atherosclerotic patients. You may not find either radial or femoral root. We can do direct punctures also. So do not lose hope. Keep fighting for these patients one way or the other. So we have certain number of patients in which we had to do direct carotid punctures when the roots are blocked. You can also think of coming from the other femoral if there is an access, or maybe a radial puncture if there is an access. So that's all from me. I think find a protocol for your place, your suitability, stick to it, and devise your own way of doing it. That's how we have been doing. Thank you so much. Thanks.
Thank you, Gaurav, for an absolutely outstanding presentation. We have just two more talks, but I would request both the two speakers to please stick exactly to time so that we can give a good bit of time for discussion. Can I call upon Dr. Puneet to talk about the post-IVT monitoring?
So basically, I'll speak on how to do what are the essential parameters we should look for after the IV thrombolysis. And I think that most of the things apply for the same parameter should be seen after the mechanical thrombectomy also, which I'll tell you right now. So I'll start. So as all of you know, in all critical cases, airway and ventilation, to look for the airway and ventilation is the most important thing. And patient with a decreased consciousness, low GC score, having especially the brainstem stroke, they are more prone to develop a airway compromise, maybe requiring intubation and on ventilator. So that should be very important thing to be monitored in the ICU setting. So whenever after IV thrombolysis, the blood pressure is a certain parameter should be monitored very regularly out of that, like a Glasgow Coma scale, the NHS scoring, the blood pressure monitoring, as well as the sugar monitoring. So these all things matter a lot, and certain other parameters which I'll tell you. So that should be monitored very much regularly, every 15 minutes in these cases. So out of that, I'll first talking about the blood pressure. So blood pressure should be monitored every 15 minutes during the 1 hour infusion. Later on also it should be monitored for 2 hours for 15 minutes. Later on, then it should be monitored every 2 hourly. The target blood pressure in these cases after intravenous thrombolysis should be kept between 185 105, and the reason is it prevents the chances of hemorrhagic transformation if you maintain, and also maintains a adequate cerebral perfusion, and while minimizing chances of hemorrhagic transformation. So that has been seen in Enchanted trial, which has very well proven about this. The blood pressure management reduces the formation of brain edema, lessening the hemorrhagic transformation and prevent the early recurrent stroke. If you see that there is a U-shaped, so if you see the pathophysiology of blood pressure, there are lot, so there the randomized trial is still lacking for that. What is the ideal blood pressure? But whatever the trials have been done, like Enchanted trial, there is a landmark trial by the Leonardo in a stroke in 2002, which has shown there is a U-shaped relationship between the blood pressure outcome and the ischemic stroke.
Given to the patient, and this advice is given to the caregivers also, because many times the patient will, even after doing the best, will have a moderate to severe stroke with some disabilities, and they may not be amenable to all the advices. And third and most important part, often forgotten, that you involve a family physician also and give advice to family physician, because it is a very useful link. So coming to these advices one by one, one is medication advice. So I am telling from my experience of last 20 years that we should always try to minimize medications. I have seen so many medications on discharge tickets of stroke patients that it is very difficult for them to keep track and give medications on time. So we should avoid multiple vitamin and mineral supplements. Yes, we know that micronutrition is a very important part, but give one single one. And use prokinetic and antiemetics very selectively, because very routinely I have seen on prescriptions using prokinetics, antiemetics, and just because a catheter is there, don't give antibiotics, avoid routine antibiotics, make the dosing intervals very reasonable. And you always mark the key medications, that these are the antiplatelets, statin, antihypertensive drugs, antidiabetic drugs, and these are the key medication. Always empower them to self-regulate certain medications. So encourage them to buy glucometers and BP monitors and ask them to self-regulate. But be careful about it, because sometimes patients do self-regulate too much. Like BP is 130, they don't give antihypertensive because BP is normal, then BP will become 180. So just guide them that if it is too much out of the range, then you can only withdraw the medication or give another dose. And you ask your pharmacist, keep a watch on your pharmacy, you ask him to give a paper envelope separate for each medication. So you can write with pen above that paper that this is the BD dose, this is the TDS dose. Most of the time, many pharmacists are putting all the medications in a polythene envelope, not guiding the patient properly. Or you ask them to make a chart as per timing, that these are the morning medications, these are the afternoon, these are in the evening. And you should always encourage a family physician concept while discharging the patient, who can be a useful link. Now, what they should monitor? So most commonly, they will monitor BP and pulse. They are very aware about it. So sugars, diabetics will monitor. So ask them to encourage and empower them to buy and use BP equipments, glucometers. Ask them to look for common complications like spasticity, frozen shoulder. You empower the caregivers for that. Ask them to report any abnormal movements also. And you give advance request for follow-up labs. If you want electrolytes on follow-up, lipids on follow-up, give an advance request. Tell them that you get the test done before coming to you. Now, there are certain things we should be very careful about in bed-bound patients, because not all the patients will do well. Many patients will be bed-bound. So you ask their caregivers to look for respiratory rates, sounds, patterns, consciousness. If they are catheterized, color and consistency of urine, amount of sputum if they are tracheostomized, what is the consistency, and you involve a family physician. So all the patients will not do well. So in these patients, these are specific things which you have to tell, because many times we have seen that after 2 months of struggle, you send a patient home, 3 days later, he comes to the emergency arrested and you can't do anything about it. Then comes to lifestyle advice. This is patients from mild to moderate stroke, and whatever ability they have, you have to advise them regular exercise. I would particularly advise to encourage sports if they are fit enough to play, because sports have both physical and mental domain. Exercise only has a physical domain. So I encourage sports, advise them adequate sleep, and advise them to prefer vocations where their circadian rhythm is maintained. And even if they have a modest intake of tobacco and alcohol, you please offer de-addiction help, because many of time they will say that my intake is very infrequent and all, but it matters a lot. And there are certain apps like stroke risk calculators. So they will quantify their stroke risk, that their risk is 5% or 10% or 20% in last 2 or 3 years. So this monitoring helps them and keeps them motivated. And then coming to the dietary advice, thankfully our Indian patients are very diet conscious. So they will themselves ask a lot of things about the diet. So first you have to ask that who cooks the food in your home. Because if a 28-year-old boy and you give him dietary advice and he has never entered kitchen, and how he'll understand, and he will not understand. So make simple diet charts, because many times I have seen that you have a printed diet charts which are very complicated. Patients will not understand. You have 15-20 things written on them, various quantities and all. So you just make simple charts that these foods are beneficial for you, these foods should be avoided, and these foods are in reasonable limit you can take. And always consider regional food preferences. Be very strict on sugar and salt. And in many rural areas, dairy products are regular part of diet. So you ask them to shift to more acceptable dairy products, like if they drink lassi, you can ask them to go for chach, curd, paneer, which are more acceptable dairy products rather than cream, butter and all. And you have to advise them to avoid all packaged, processed and fast food, regardless of their content. They should be avoided. And of course, for RT patients, you need professional help from the dietitian to make adequate pastes and solutions to feed them properly. Now coming last to the rehabilitation advice. So you have to keep their motivation high, number one, and you have to do that by setting realistic short-term targets, that what you can achieve, so they will be more motivated. And you have to empower caregivers for home rehab. One thing we have not understood, that many patients are calling physiotherapists daily to their house, and it is actually very costly. And over a period of 2 to 3 months, their rehabilitation costs become very enormous. So you have to always empower caregivers. You ask them that active, passive mobilization, range of movements are good enough, and many times fancy equipments doesn't help much. So they can continue with their rehab. And cognitive rehab is an important part of rehab. So always inquire about patient's mood, behavioral changes, whether he has any neglect and all. And you have to identify good physiotherapist, good speech therapist and psychologist in your vicinity, because I have seen that there is wide variation in their ability. Some physiotherapists are really very good, some are not good at all. So what I do, most of the time I visit my rehab department saying that I have a knee injury, I have an elbow injury, I have a shoulder injury, and then ask them to help me. So it's like a malingering, but it helps me identifying that who is good and who is not. So thank you so much.
Thanks. We are very much in time. If you have a couple of questions, please, we can only take a couple of questions because it's 10 past 10. If anybody has a question or you think the whole workshop was so very good that you don't require any doubts. Anybody? Yeah, I saw one hand there.
My question is to Puneet.
Yeah. Puneet, Gaurav, please. Dr. Mahajan.
So all the recommendations were in sync with the guidelines. So my question is to take your opinion on the role of fibrinogen concentrate versus crowd acetate for management of AIS thrombolysis related, because even crowd acetates requires oil, requires ABO compatibility matching, whereas the newer preparations like Riasat, which is a fibrinogen concentrate.
APCC, activated prothrombin concentrate or fibrinogen concentrate? Fibrinogen concentrate.
So what's your take on that? As a jugaad, like to infuse the patient with Riastat, that is a fibrinogen concentrate, and later with FFP. If you don't have the cryoprecipitate facility available at the school,
What's the question? I think that definitely if you're not having cryoprecipitate facility, that should be available there. Given cylinder, the fibrinogen concentrate can be given. It does not require the ABO matching also. And and later on you can supplement with the although FFP, the problem with the FFP is that the action starts late in the FFP, require a rapid action. So the best part is the first, I'll say, is the first will be the cryoprecipitate. If it is not available, the fibrinogen concentrate can be given, and in complements with the FFP and platelet concentrate if required. So, but we have facility of cryo. We are given few patients, so that can be given if it is available.
How frequent do you recommend serum fibrinogen level monitoring?
So serum, if you see if you are using cryoprecipitate, the peak action occurs after 1 hour, and the effect lasts for even up to 6 to 10 hours. So after usually fibrinogen level should be done after giving cryoprecipitate after 1 hour. So it should be sent after 1 hour, and if the fibrinogen level should be more than 150 or around 150. If it is reaching that, then repeat dose is not required. Otherwise, you have to give a repeat dose of cryoprecipitate. That is 10 units again.
Thank you, Puneet. Any other?
So I have two basic questions. When should we catheterize the patient of stroke? Before IV thrombolysis or after IV thrombolysis? If it is
So before IV thrombolysis, catheterization usually should not be done. The only issue is that many times when you're going for the MT, mechanical thrombectomy, then or a patient definitely having unconscious patient, in those cases after thrombolysis, sometime if it is required, really required, in those cases you can do the catheterization after the 2 hours to 6 hours. After 2 hours of the thrombolysis, you can do that.
See,
Or after people have done even after 6 hours also. But usually should be, if it is avoidable, then it should be avoided after thrombolysis.
it's a second basic question to you, sir. It's a in wake-up stroke. We know that if there is diffusion flare mismatch, then we should thrombolyze. So is there any objectivity in terms of volume, in terms of percentage, like how much it should be there? Because there are two sequences that we should go ahead with thrombolysis.
We do follow the 50% rule. So basically, if it is more than 50%.
can you use the mic?
More than 50% area is involved.
So less than 50% is more than we should go ahead. So my third question is to you, sir. What is your normal protocol in patients who have poor riding after 6 hours with and in whom we are suspecting large vessel?
So very simple. So very simple for all the patients from 0 to 24 hours, we do CT, angio and CT perfusion at the same time. Because if you start selecting patient that I will do CT now, then decide, then do a CT angio, you waste a lot of time. So it's straight away from emergency to CT, do all these three things from 0 to 24 hours until unless you are suspecting a stroke mimic, and then you do an MRI. Otherwise, it's a standardized protocol.
I think we should wind up because it's past time. Thank you very much, all of you, for being here. Thanks, Gaurav. Thanks, Dr. Mahajan. Thanks, Dr. Bhutani and Puneet. It was absolutely an outstanding workshop. And I hope all of you have got the enthusiasm that you go to your own center, tell your administration or whatever it is to send up stroke center. And if we can be of any help to you, you're always welcome. Thank you very much for being here. Thank you, everybody.
Thank you so much, speakers, for covering the topic of stroke so extensively. Now, may I request Dr. Gaurav Goel, sir, to please come on the stage and felicitate Dr. P N Renjen, sir. Dr. P N Renjen, sir, please. So we can. Now, once again, may I request Dr. Gaurav Goel, sir, to please felicitate Dr. Puneet Agarwal, sir. So once again, I think they're clicking. Now I request Dr. Gaurav Goel to please felicitate Dr. Neeraj Bhutani. Thank you so much.
To 150 is a critical level, which leads to the decreased mortality as a dependency after 3 months. If you maintain around that, if it is more than that, so or you can see earlier there was a certain study have shown MAP also, mean arterial pressure. If it is kept in patients who are having a in after thrombolysis should be kept between 120 to 130 initially, and followed by 110 millimeters of mercury. So that's also some of the study have shown should be the target. But nowadays the systolic blood pressure is supposed to be most culprit, and targeting the systolic blood pressure and also diastolic in the range of less than 180 105 for next after the thrombolysis is required. And the patients who are having and the patients who are hypertensive, you can reduce the blood pressure by 15% only in first 24 hours. Patients who are having a high blood pressure more than before thrombolysis or even after thrombolysis, in those cases these IV drugs like labetalol is a drug of choice can be used, but except certain contraindications. So we use labetalol very frequently, but we should be aware about the contraindication. Many times you keep on using, patients are having asthma, patient having severe heart failure or cardiac heart blocks. This is one of the contraindication, and many times we keep on using labetalol injectable. In those cases, the only drug available in India is enalapril. So we can give 1.25 to 2.5 mg IV of enalapril. The nicardipine, clibidipine is not available in those cases. Now, besides the blood pressure, the monitoring the neurological deterioration by measuring the NHS scoring, especially and GCS scoring every 15 minutes for first hour infusion, then 30 minutes for next 6 hours, and then hourly for until the 24 hours that should be done. If any decline in the NHS scoring, then patient should be subjected for the CT scan. If the altiplase is going on, then it should be stopped immediately, and the CT scan should be done to rule out any hemorrhage. Because NHS scoring has a linear correlation, it has been found with the 3 months outcome. In these cases, patients who are having severe NHS scoring, the outcome is bad. In those cases, if there is a deterioration in the GCS or NHS scoring, the TPA, if it is going on, should be stopped. If it is not going on, then patient should be subjected for CT scan to rule out any hemorrhage. Some of these cases rarely can develop orolingual angioedema after TPA, which is present in 0.02 to 0.05% of cases, in which there is a swelling occurs and there is a sudden choking, and the desaturation can occur. The treatment in these cases is, again, the intubation may or may not be required if there is a fall in the PO2 level of rising PCO2, and followed by IV methylprednisolone 125 mg, IV diphenylhydramine 50 mg, and IV pantoprazole or ranitidine should be given in all these cases. Now, what's happening? So we should continue to monitor the blood pressure, as I've told you, and patients anticoagulation, antiplatelets should be started after 24 hours of the TPA infusion or tenecteplase infusion. The LMWH anticoagulation, if required, should be used after 24 hours of the therapy. Statin can be given immediately after the thrombolysis, or even before thrombolysis. Usually the statins are given, and that should be continued. Now, regarding the blood sugar, should be monitored regularly in these cases. The target blood sugar is now 140 to 180 milligram% for in patients who are thrombolizing. Or hypoglycemia should be treated if it is less than 60 milligram% by infusing that 25% dextrose. If the temperature is high, more than 38 degrees, then it should be corrected because it can lead to raise in the intracranial pressure. So there is a class 1 CLD evidence is there. The hypothermia, induced hypothermia role is uncertain. In these cases, after stroke, usually it is not used. The airway protection definitely should be done. If patient GCS score is going down less than 8, patient may be requiring intubation and mechanical ventilation. Patients who are having oxygen saturation less than 94, then only there is a role of providing the supplemental oxygen. Otherwise, there is no role of giving oxygen therapy in these cases. There is no role of hyperbaric oxygen, which is given, which was studied earlier also in many cases. Now, patients developing this again important thing. The patients who are having decline in the GCS or in the scoring and the CT scan, the commonest complication is a hemorrhagic transformation, which is ranging from 3% to 5.4, 5.5% after altiplase, and even the altiplase, the range of hemorrhagic transformation is almost equal. So that if that is there, then we can see that there are 4 types of hemorrhage can occur. One is a H1 hemorrhage, in which there is a small petechiae there. There is a S2 hemorrhage, more confluent petechiae. The PH1, PH2 hemorrhage are definitely are matter of concern if they are present. In PH1, there is a less than 30% of the infarcted area is having hemorrhage, and PH2 there is a more than 30% of infarcted area hemorrhage with a significant mass effect. So these are the patients who require treatment most of the times. And if you see that the hemorrhagic transformation after ischemic stroke, that the hypertension is the most important thing in those cases, which is to be more, or the uncontrolled blood sugar in these cases, or even the largest stroke. It is a reason for the hemorrhagic transformation in most of the cases. Now, after detecting the spontaneous hemorrhagic transformation, the patient should be subjected for the therapy, either medical therapy as well as followed by the surgical therapy in form of decompressive hemicnectomy. Especially patients who are having a PH2 hemorrhage with a midline shift, the surgery is required in most of the cases. The treatment for cases who are having a S2 or a PH1 hemorrhage and are symptomatic, there is a decline in the NHS scoring. In those cases, the cryoprecipitate is a drug of choice, which is 10 units should be given in 10 to 30 minutes, and measuring the fibrinogen level. If it is less than 150, then after 1 hour, you can repeat the dose of cryoprecipitate. Tranexamic acid of 1000 mg IV infused in 10 minutes can be used, or aminocapric acid, where these cryoprecipitate cannot be given, can be used as an alternative treatment. Other therapies like platelets, FFP, they have usually no significant role in cases of hemorrhagic transformation after thrombolysis. The vitamin K, APCC again has no role in patients who are having hemorrhagic transformation after thrombolysis, but APCC definitely is drug of choice for patients who are having vitamin K antagonist related bleed like warfarin, fumarin related bleed, or patients who are having a direct thrombin inhibitor like apixaban or rivaroxaban related bleeds. So the initial blood pressure is whenever the hemorrhage transformation occurs, the blood pressure management is very important to prevent the hematoma expansion, which can occur in next 24 hours. And target blood pressure should be less than systolic, especially should be less than 140 in all these cases. So this is a basic algorithm for appropriate medical and surgical approaches of hemorrhage transformation after stroke, ischemic stroke, which I have told you right now. And you should go with this. The medical therapy as well as the surgical therapy, surgical treatment can be done in these cases. Thank you.
Good afternoon, delegates. I seek your attention here. So first and foremost, welcome to the hands-on workshop at the WNS. We are going to have a hands-on session on Sylvian facial dissection. We are fortunate to have Dr. Vivek Tandon with us, who's going to mentor the session. Sir is a professor at the Neurosurgery Department of AIIMS New Delhi, has been active faculty and helping us to educate more than 5-10 years now. So with this, I welcome Dr. Vivek Tandon. Dr. Tandon. So request you to address the audience.
Very good afternoon to all of you, and thanks to the organizer, I am here to teach you. I believe that all of you are in the training, or some of you might have just passed out of your training. And I believe this is not the forum to talk about the anatomy, how the Sylvian fissure looks like, where the anterior ramus is, it is superficial, deep. I believe we should start giving them the brains, and so that they can have a hands-on practice. So at least for 1 hour or maybe 30 minutes, you should practice how to open it. I'll just show you, I'll tell you some of the basic steps, and then you can take it on from there, because this is one of the skills that you will be required. And the basic skills are same, that in neurosurgery, you should not be trying to use muscle power, but the finest possible movement is at the fingertips of yours, not even at the palm level. And it is the fingertips that you should be moving to be doing this dissection, okay? So most of the surgeries which you will do in the brain, for example, craniopharyngiomas, aneurysms, I mean any skull-based surgery, you will have to dissect out Sylvian fissure. It's a basic technique that all of you should know and understand, okay? So let us start giving them brain, and maybe I can mentor them while they're doing it, rather than telling them or showing them some video or doing something like that, okay? So they all will get a brain, or they all will get a brain?
फोकस कनेक्ट कर रहा है.
Dissecting Sylvian fissure in a human, it's easier in comparison to doing it on a brain which is like this, which is of an animal, and it's a dead brain basically, because there is no CSF. And similarly, when you are doing dissection in the Sylvian fissure, at times it's easier to dissect if there is some CSF which is there, because then the arachnoid is displaced and it's away from the veins. And occasionally when you see patients where there is arachnoid, blood is there, that it will be stuck with the veins and it becomes difficult to dissect. In these kind of circumstances, some of our residents are here, who are just very recent pass out. I usually ask them to push some saline. Keep pouring saline, keep pouring saline. It clears the field, fills up the arachnoid space, and it becomes easier. So I don't know, I mean, how good this brain is. We will try, and we will see how it can be done. And if the Sylvian fissure has already been dissected, because I see some of these brains have already been used, then you can try opening any other fissure. It's still okay, because the technique is same. Sometimes you go transsulcal approach for glaucoma or any other surgery, and it's the same technique which you will have to utilize again and again. So don't get bothered if you're not able to find a good Sylvian fissure. I mean, just try opening any sulcus, try going deeper into that sulcus, and try opening that sulcus slowly, so that you can go and visualize the gyrus at the depth. Okay? Doing right now? You continue to do whatever you are doing. I just want to show them. You just do whatever you are doing. I forgot to take a picture of yours. So the first thing is that, see, his hand is placed above like this. trying to do is trying to place his fingers to stabilize the hand. So the first thing is that your hand is stable from here. It is stable from here, and then you stabilize your wrist. Okay, the base is same everywhere. You stabilize your wrist first, and then you stabilize your finger by this finger of yours, or two fingers, and then your movement has to be by these two fingers of yours. Okay. Similarly for this arm, if you try holding your arm like this in the air, it becomes.
आईपीडी कितना करना है? जीरो ही है सर, जीरो है सर ये, बाकी ये इस साइड से।
अच्छा, फोकस करो इसको, कैसे करते हो?
देखिए
डिसेक्शन ही नहीं, फोकस ही मुश्किल है। हाँ, कुछ बेटर बट क्लियर अभी भी नहीं है मेरे को। हाँ, अभी थोड़ा सा तो क्या खोल के देखा जाए? हाँ ठीक तो है, नहीं ठीक नहीं, अब तो चला गया और चला गया। और करो फोकस, और करो, ठीक है। जूम आउट कर सकते हो क्या? जूम आउट कर सकते हैं क्या? ठीक है, तो ये वाले फिशर को, इंटर हेमिस्फेरिक को खोल के देख लेते हैं। और क्या खोला जा सकता है? इसमें ये है शायद सिलियन फिशर, इसका एनिमल का। So earlier what we used to do was, we will take the arachnoid knife and cut it. Then someone amongst us used to use diamond knife, then scissors, everything. But what I have realized is that you give one small nick. Do we have a fine needle or a knife here? कोई, ये तो scissor भी बहुत मोटी है, कोई needle या knife है क्या? कोई fine needle या knife हो? Now what most of the times do is, if you don't have these very expensive equipment, nothing is required. Your insulin needle is good enough. Okay. So we use just this needle is even bigger, but we take the insulin needle, and is there you see here, we just cut it like this. Okay, this fissure. So this is the arachnoid. There is no CSF here, unfortunately. So we usually ask somebody, do we have some saline also or some water in syringe? Can we take it? इसमें डाल लो पानी, वरना कोई पी लेगा थोड़ी देर में। So what we can do here is, we can try just inject some water here. You see, it will make our life easier. Can you see it is getting expanded? Can you see here? Okay, so it gets expanded. Then you can utilize any tool that you have. You can use some scissor. This scissor is not a very fine one, but you can just put the scissor here and slowly start dissecting it. Okay. Can you see the vessel here? Now, once you have done that, it is very easy to damage the structures below with the movement of your hand. If you have good forceps, you can use the forceps to place it like this, and you can just tear it. Can you see what I am doing? Can you see? This will never damage anything. So just apply good traction, not more. Hold the arachnoid gently and separate it. Can you see I have not damaged anything? Can you see here? Now you can use any cotton, small piece of cotton here, place it, or the best instrument which I find in my setting is the bipolar. It is sufficiently blunt and it is good, it doesn't damage the cortex. So you can put it here and you can dissect slowly. Okay? Slowly and slowly. You continue to dissect, you provide some counter traction. Can you see even in this animal, you can see this vein, it is here. Can you see this vein, which is here? And the small arachnoid, please don't shake my table. And can you add some more saline here or water here? So you continue to dissect it like this. So just practice this. You can continue to go into the depth and identify the structures. This is what you have to try and do. So just try open any other fissure, whichever you think is the biggest or the largest one. You start with that. Try preserving the vein like I have done. Make a small nick and then do it. In this case of Sylvian fissure, like there is a vein here. Sometimes you have to dissect around the vein. Then you have to decide which side you want to dissect on the vein. You want the vein to be on frontal side, you want the vein to remain on temporal side, and you need to see like this vein is coming from here to here, and probably there is a tributary here at this point. Okay? So if I have to go in this fissure and I have to go here in the deep, I don't want to be going on from this side. I will prefer dissecting this vein from here to this side. Okay? So this is what you have to see once you open. I mean, just don't start dissecting. Just have a look with the microscope where you have to go, what you have to do, which side you want to go, and then don't injure that thing. Okay? So just start. See, all these things, they are all written in books. Frontal side, temporal side, ascending ramus, this ramus, that ramus. Every patient is entirely different. I have realized every patient is entirely different, and you need to be clear what you are going to do in that patient. I mean, is it a craniopharyngioma? Is it an aneurysm? Do you want a huge dissection to be done? Which side you want to see? What side is the tumor? What is going to be your directional approach? Based on that, you will have to take a decision. Okay. But yes, most of the times you can dissect the veins towards the frontal side because it is easier to do that. But sometimes, I mean, the anatomy is such that veins are only on the temporal aspect. Then you go from the frontal aspect. Okay. So just try exposing like this. In the depth, if you will go, you will be able to reach the depth of the sulcus. There will be an artery and there will be a vein. Okay. So you can utilize any fissure to open that. Try first with the biggest fissure that you can see. तो इंसाइज करो उसको कहीं पे लाइन डाल देना इसमें, पुश कर देंगे। इसको ऊपर पुल करो, नहीं नहीं, हाँ यहाँ से इसको रेक्टोइड को पुल करो इसकी, बस हाँ लाइक दिस, अब डिसेक्ट हो जाएगा। पुल करो उसमें, एक्चुअली के अंदर तो इसका सिलियन फिशर ये है, कोई बात नहीं है इसको, सपोर्ट actually cylinder pressure will be here. No, lift it like this. हाँ ये वाला ना, ये वाला है, हाँ ये वाला है, इसको ब्रेन को पोजीशन में लगे ठीक से। दिस इज एक्चुअली cylinder, दिस इज टेम्पोरल लोब, दिस फ्रंटल। ये क्या यहाँ कर लिया, डेप्थ के लिए तो इसे खोलना पड़ेगा थोड़ा सा, ये तो थोड़ा सा कोर्स है, अरे यार ये तो ख़राब है। ये तो ये देखो, ये बड़ा सिल्वर फिशर एक्चुअली में यहाँ पर है, इसको उठाओ, ये यहाँ पर, ये दिख रहा है, इसको पोजीशन कर, तुम भी ये कर। नहीं वो नहीं है एक्चुअली में सिलियन सेशन यहाँ पे इसको ऐसे पोजीशन में ये वाला पोजीशन ये है ना ये फ्रंटल लोब है ये उसका टेम्पोरल लोब है ये सर्कल बीच में इसका सिलियन सर्कल का एक्चुअली ये है ये फ्रंटल लोब है ये टेम्पोरल है ये टेम्पोरल है ये सिलियन ये आ रहा है पूरा डेप्थ तक जैसे ह्यूमंस होते हैं वैसे ये तुम्हारा कितने देर का सेशन है ये अभी तो ओके नहीं आई मीन इट्स देयर विश ठीक है ये कब तक करना चाहते हैं बिकॉज उन्हें सिखा तो दिया ही मैंने वो नाउ दे वांट टू प्रैक्टिस दे कैन प्रैक्टिस दे वांट टू लीव दे कैन तो अच्छे हैं प्रेजर्व अच्छे हैं ब्रेन अच्छे ब्रेन प्रेजर्व है वही मैं सोच रहा था शीप ब्रेन तो मतलब थोड़ा छोटा होगा वो प्रैक्टिस की बात है करने वाले 5 मिनट में कर देते 2-3 मिनट बट वो कभी कभी टाइम लगता है सीखने में तो टाइम लगता है क्योंकि एक्चुअली में वो नहीं है गड़बड़ हो गई तो उसके बहुत पेनफुल है उसके बाद फिर वो रिट्रीव करना बड़ा मुश्किल हो जाता है
एक बार सर अगर कुछ हो गया तो ट्रेन में तो
सारा प्रॉब्लम उसी का है अच्छा कल तो यार मेरा
डमीज पे फैंटम पे ना
तुम्हारा कितने बजे तक है एक्चुअली में कल यहाँ पे सेशन
सर हमारे डाइटिंग में बाद में पोस्ट लंच खत्म हो जाएगा
हाँ भाई कल मैं एक्चुअली आज मेरे घर पे आई मीन फ्यू रिलेटिव्स आर कमिंग दे आर ऑलरेडी रीच्ड
सिल्विन भी करेंगे डॉक्टर गुरबच्चन
somehow I missed your mail actually मेल मिस हो गया फ़ोन मैंने उठाया नहीं ओ फ़ोन नंबर सेव नहीं था ना तुम्हारा मेरे पास में अदरवाइज यूजली होता नहीं है मैंने मैसेज भी देखा तुम्हारा तो जब उस दिन फ़ोन नंबर सेव किया देन आई रियलाइज दैट देयर वाज अ मैसेज लॉन्ग टाइम बैक तुम क्या वेयर आर यू?
Sir, I am supplement assistant.
अच्छा, यू आर इन सप्लीमेंट, ओके। आई थॉट यू आर इन मेदांता। नहीं, यू आर इन मेदांता, ओके। सो वेयर इज डॉक्टर करण? हाँ,
तो पता ही है
क्या?
दोनों यूनिट का इशू है।
अच्छा, ऐसे है।